Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. June is Cataract Awareness Month, and cataracts are the leading cause of blindness worldwide. According to the Centers for Disease Control, West Virginia has the highest prevalence rate of visual acuity loss in the nation, with 1 in 30 residents suffering from blurred vision or smaller field of view. Gradual loss of vision is caused by several eye conditions, including cataracts. So today, we're talking about cataracts and their treatments with Dr. Brian McMillan, glaucoma specialist and ophthalmologist at the WVU Eye Institute. Welcome, Dr. McMillan, to Live Healthy West Virginia.
Thanks so much for having me. I'm really excited to be here.
Yeah, we've got a lot to cover today, so we're happy to have you. So let's start first with, what exactly are cataracts?
It's a great question. So cataract is actually the natural lens in the eye that becomes cloudy over time. Then when it becomes cloudy, we change the name and call it a cataract. So it does lead to some confusion sometimes, because sometimes people feel like it's something that can be peeled off the eyes or in the surface of the eye, but it's actually the lens in the eye, but we change the name, call it a cataract when it starts to become cloudy.
Okay. So are cataracts very common?
Cataracts are very common, and the old adage goes, if you live long enough, you'll develop a cataracts, because age is one of the most common risk factors for developing cataracts. So yes, they're quite common.
So is everybody going to get them? I mean...
Typically, if you live long enough, yes,
okay.
You can develop cataracts. And cataracts can develop from other things too. Even young children can develop cataracts. So the different conditions that lead to cataracts, diabetes, for instance, a very common condition, does lead to cataracts more quickly than patients who don't have diabetes. So yes, it's a very common condition.
When my dog got diabetes, he got cataracts.
Yes.
Yeah, that's a very common thing. What causes cataracts?
So cataract being the lens in the eye that changes and becomes cloudy over time. So it can be anything that can lead to fluctuations within the lens. So blood sugars, which is what brings us to the diabetes, that can change over time within the lens, leading to cloudiness. Certain medications, steroids is the most common, can lead to increased cataract risk. And then age. And so age is either just from time, or is it perhaps UV exposure? That is one thought that can increase the rate of cataract development. But the biggest thing is just time.
So at what age do cataracts usually start?
So as an ophthalmologist, when you're looking at the patient in the microscope, you'll start to see some changes in the lens, maybe in the 40s, or definitely by the 50s, you'll start to see some change on the microscope. However, the patient usually doesn't start to have symptoms till a bit later. About 1 in 5 or so patients will have visually significant cataracts in the 60s to 70s, and that jumps to about 50% of patients in the 80s.
Wow.
So gradually, as you get older, your average type of cataracts become more common.
Okay. So what are symptoms of cataracts? What do they look like when they're in your eye?
Great questions. So on the exam, we start to see cloudiness, usually a coloration change going from clear when you're younger, to more yellow, eventually brown. Some of the darkest cataracts can be red or even black appearing underneath the microscope. Some will turn and be completely white even during the exam. And so those are some of the more advanced types of cataracts. But symptoms that patients will notice will often be, earliest signs would be a general blur or having more and more difficulty in certain lighting conditions. So glare at nighttime while driving is a very common one, or requiring more and more light in order to read is probably the next most common symptoms. As things start to progress a little bit more, people will start to notice halos around lights at nighttime, or even doubling of the image in that eye. It's more of a shadowed effect as the light goes through it and starts to split as it hits the lens, rather than being focused nicely to the retina.
So it's not just blurry vision, right? I mean, if it's blurry, it's pretty advanced?
Well, the blurriness will depend somewhat on the lighting and also where the cloudiness of the lens is. So there are different types of cataracts. So depending on where the cloudiness is, if it's in the center, then you'll start to be blurred at all times. But certain lighting conditions typically make it worse, because that's when you get the scattering of light when it hits the lens. and that's when patients become really symptomatic.
So you said there are different kinds of cataracts. What are the
Yes.
different kinds of cataracts?
So we name cataracts depending on where the cloudiness of the lens is. So
Okay.
if it's in the center part, which is probably the most common cataract, we call it a nuclear cataract because that's the center or core of the lens, right? And then people with diabetes that may develop cataracts, or people on steroids, will tend to get cataracts on the back part of the lens. So we call those posterior, back part of the lens, subcapsular cataracts. So it just tells us there's a sheet like of cloudiness on the back part of the lens. And there can also be cortical cataracts, which are like spoke-like cloudiness, which tends to be more in the front part of the lens. And there's still yet even more different cataracts, but those are the most common types that we see.
Okay. All right. How do you diagnose cataracts then?
Great. So to make sure it's the cataract, you really need to do a full eye exam. So we see patients, we do their vision, we inspect the front part of the eye. It will often be dilated so we can see the lens more fully, and then assess the back part of the eye to make sure that there aren't any other problems that could be causing the blurred vision as well. And then we, of course, look at the lens, and we try to pair what the patient's vision is on the chart with how cloudy that lens is. And generally, you can start to make a conclusion that the amount of cloudiness that you're seeing is representative of the vision loss that you're seeing once you've ruled out any other problems that could be affecting the eye.
Well, you mentioned dilation, what school are you in here on dilation? Because I know there are some doctors that offer, they're like, well, you don't have to get your eyes dilated, you know, for the exam. You can, we can take a special photo.
Yes.
But I know that there are some doctors that think, those photos aren't as exact as when you're dilated. What's your opinion on this? Let's cause some controversy.
Good points. So the technology on non-dilated eye exams for photos has gotten much, much better. So that's where that option has become more of a reasonable option to do. Say 10, 15 years ago, probably wasn't a great option because there'd be parts of the retina you wouldn't be able to see. So that has gotten better and better. I'm still in the camp of we should do a dilated exam because you can see directly with our lenses most of the eye. And if we need to see yet even more areas, we can do special parts of the exam to see areas even further out with depth perception because we're looking through binoculars on our microscopes. So I think the best exam is still a dilated exam, particularly if you're assessing the cataract, because there may be parts of the lens that you aren't able to see with the patient undilated. But as just a general rule with eye exams, for screening exams, it's probably the most appropriate setting when you're not as worried about any particular type of disease, but you want to get an idea of what the back part of the eye is doing.
Okay. Who's most at risk for getting cataracts?
Well, that would be your older population. So as you get into those higher percentage rates, the 60s, 70s, into the 80s is where you're going to be most likely developing cataracts. Although I've seen some patients much older than that seem to do just fine with the amount of cataract that they may be having. Of course, they have some level of cataract, but the question is always, is it a visually significant cataract, meaning is it affecting your quality of life in some way?
Right. Can you do anything to prevent getting cataracts?
Well, there's not a lot you can do. You don't really want to change the number one risk factor, which is just getting older. So there's nothing we can do with that one. But there's some thought that perhaps wearing sunglasses to decrease UV exposure is helpful. Having a general healthy lifestyle where you can control your blood sugars, particularly if you have diabetes, controlling your blood sugars to minimize the risk of developing cataracts, or just decreasing your likelihood of developing diabetes would be a big one. And then some of the things you don't have control over, like if you need steroids for a certain medical condition, you might still need them. But if there's a reason why you're needing those steroids, if you can decrease the risk of that particular condition, that would decrease the likelihood of some of those medication-related cataract changes.
What about eating carrots? Is that a myth?
Carrots have beta-carotene in it, which there can be metabolized into a compound that's used by the retina. So it is helpful in vision development or vision processing, but likely in our North American diet are not going to be too deficient on beta carotene. But in general, yes, eating vegetables is a good part of a healthy diet.
All right, good to know. All right, so how do you treat cataracts? What are the options?
Great. So once the cataract has gotten to the point where it's visually significant and affecting vision, then we talk about cataract surgery. So to do cataract surgery, we have to make an incision in the front part of the eye. We break up that cloudy lens, remove it, and insert an artificial lens, basically in the same position that the natural lens was. There's a thin membrane that's left over that we leave in position, and that's what saran wraps around the artificial lens that we implant in the eye. And so there are lots of different options for lens choices at the time of cataract surgery, as the technology in both measuring the eye as well as building those lenses has improved over time. So the number one goal when considering cataract surgery is that you get the cloudy lens out and a new clear lens in to help to focus light. So that's the real purpose of cataract surgery.
Right.
But with this additional technology and improving methods of measuring the eye, we can start to fine-tune things to maybe we can minimize the need for glasses at distance. If we have astigmatism, we might be able to take care of that at the same time.
Really?
That's correct. There are special lenses that we can build astigmatism correction into. And then there are also even multifocal or presbyopic lenses, which means you can split the light up that's coming into the eye into multiple focal points to increase the range of vision, decreasing the dependence on reading glasses.
So like I have progressive lenses.
Yes.
So could you, if I develop cataracts, could you give me like a progressive lens as opposed to just a regular lens?
Kind of. So
Okay.
in order to do that, since you're looking through the lens is going to be there at all times, and the light comes through the eye, hits the lens, and then is focused in the retina. So that's basically how it works. So in order to have a larger range of vision or multiple focal points, which you do if you're looking at distance or if you're looking up close, you have to split that light somehow. And so how the lens technology is doing it is there are little rings that are etched within the lens that can separate out the light waves into multiple focal points. So there are some potential downsides with that, is because you are splitting the light. You may not get as much light to each individual focal point. But for patients who are highly motivated to try to get rid of reading glasses, it can be a nice option. The rings perhaps could give some halos around lights, or perhaps some glare. So there could be some downsides that I'd recommend that someone talks to their ophthalmologist about when they go in for consultation to make sure this is a good option for you individually. But there is some really interesting technology that could be helpful to serve a wide range of patients and what their goals are, not just to get the lens out, but you have other goals as far as glasses wear after surgery.
Wow, okay, good to know. So if we're going to have cataract surgery, what's involved? Tell me, what should we expect? I'm assuming this is an outpatient procedure.
It's an outpatient procedure at WVU. We still do our surgeries in the main hospital, so you'd still be coming into Rubin Memorial Hospital, but you'd be on the outpatient floor. It's the second floor of the hospital. So it's an in and out procedure. You come in before the surgery, you do the things that the nurses need to help to get your eyes dilating, as well as doing all the proper documentation for a normal visit. And then you go back for surgery. Surgery varies, but around 30 minutes is a rough estimate, or shorter, depending on the type of cataract. And then you recover and go home. So you spend maybe a good half the day with us or less. And then you're checked the following day, 1 week after and 1 month after, to make sure the eye's healing up the way we like to.
Are we awake for this?
You're in twilight, so you got some medicine going.
Twilight's good.
Twilight's is good. So you're relaxed. So I tell patients, if you're anxious or you're nervous at all, just tell us. You'll be twilight, so you don't care. But if you do care, tell us, and we'll make sure you don't care.
Okay, you can make that adjustment. There are a lot of older people, I think, that sometimes when they think of cataract surgery, they're afraid. What if I lose my eyesight or something? So what do you tell to people that are apprehensive about cataract surgery?
I think probably the most important thing is to realize that I understand. It's you're having surgery. One, you have a surgery on your eyes. Two, and you're probably having difficulty right now, and you really like to see better. There's a lot of, we spend so much using our eyes. Our lifestyles are often centered around our vision, and the thought of having something work out not the way you like, and that can be really nerve-wracking. So if someone is particularly nervous, then I validate their concerns, because it's reasonable to be anxious about having surgery. But then I also remind them that it's one of the most common surgeries that's done in the world. The outcomes for cataract surgery are excellent, in the high 90 percentile of outcomes. And the risks of surgery are generally very low in the hands of experienced surgeons. So the risk of infections are extremely, extremely low. We give antibiotics at the time of cataract surgery, which has now made that risk exceptionally low. And the odds of having to go back for a second procedure are also fairly low. So the success rate is thankfully very, very good with cataract surgery.
So if we do find out that we do have a cataract or we have cataracts, why do we sometimes have to wait? Because like there's part of me that's like, get it out right. now, you know?
Right. So I think that's where understanding what is going on is helpful. So once you know it's the natural lens that's always been there, just starting to become cloudy over time, then that can help to decrease the need to just try to get rid of this problem that you have. But at the same time, if you're not noticing it, it's affecting your quality of life, then that's when we don't need to do anything about it. And so we just discussed how low risk cataract surgery is, but it is a surgery. You are in the eye, working on the eye, so there are those potential risks that go along with it. So you want to make sure that the risks of doing the procedure are outweighed by the benefits to the patient of having that surgery done. Okay. And so as a doctor, you always want to try to help improve things. And so we have some guidelines to where we can show that the risk of doing it is now outweighed because the person is having trouble not being able to see to drive or do the things that they want to do in life. This is very much a quality of life improvement surgery. So if you have any problems that are affecting your quality of life, then it's time to start thinking about having cataract surgery.
Once you discover it, does it tend to progress get worse pretty quickly, or is it kind of a slow process?
In general, it's a slow process. It would depend on what type of cataract. We reviewed that there are a few different types of cataracts, and some of those can come on a little more rapidly than others. But your average cataract is generally slowly progressive. And so it's a matter of informing patients about the symptoms like we just discussed. And when you start to notice them being more problematic, then that's when it's really time to start considering surgery.
Now, I want to ask if this can this be a symptom of cataracts? My husband has worn glasses for 50 years. And last year he said, you know what? I don't need my glasses anymore to watch television. I feel like my sight's getting better. And he went and saw his eye doctor. And she said, yeah, that's because you're starting to get cataracts. So, do cataracts actually improve your vision or what?
Right. So it's an interesting phenomenon. It's known as the second sight, if you will, because particularly in patients who are farsighted, where you have difficulty seeing at distance, but that's the sharpest vision, and then even more difficulty up close, you can get a shift towards more nearsightedness as a cataract develops. So if you think of the cataract as a lens, but it has layers to it, much like layers on an onion peel.
Okay.
So as an onion gets bigger, it gets thicker and wider.
Yeah.
And so as light goes through a thicker, wider lens, it focuses more readily and actually starts to shift the eye to be a little bit more nearsighted. Oh. So in people who are farsighted, if you start to become a little more nearsighted, that shifts you from being farsighted to almost maybe no lens prescription. And then that's where your distance vision might sharpen up. Or you might find that if your distance vision is relatively sharp, you might find that you're able to most patients would be presbyopic or having difficulty seeing up close. They might start to do a little bit better up close as that cataract develops and gets a little bit thicker.
Okay, good to know. We were talking earlier about that when you're in there doing cataract surgery, you can also do minimally invasive glaucoma surgery while you're in there.
That's correct.
So explain me, who would need to have cataract surgery and glaucoma surgery, and how does that all work?
So might be best to talk about what glaucoma is first.
Yeah, that's a good idea.
Glaucoma can be a bit of a difficult topic to understand. So glaucoma is damage that occurs to the optic nerve, which is the back part of the eye, partly related to what the pressure is in the eye. So the diagnosis isn't what the pressure is, but the only thing we can change in the eye is to lower the intraocular pressure. That's all our drops, lasers, surgeries, they all work to lower the pressure. That's where we currently are with glaucoma treatment.
Okay.
So in a patient that's undergoing cataract surgery, in the front part of the eye, there's a drainage system where the fluid in the eye that moves around the lens up to the front part of the eye, circulates, nourishes the front part of the eye, but also gives the eye a pressure. It goes into the drainage system and eventually percolates to the bloodstream. That's how it works. And so since we're in the front part of the eye and we're working on the lens, we can reach across and open up the drainage system to help to improve the outflow of fluid through that drainage system, therefore reducing the intraocular pressure. And this is something that really started to come about, about 15 years ago with the eye stent procedure. It was a trabecular micro bypass stent is the full name for it. It's a little device you can put in the drainage system.
Which is what is that?
It's a little stent, the smallest implantable stent. It goes right in the drainage system to help to get fluid more directly into the drainage system. So that's where things started. And now it's opened up to a large option of minimally invasive procedures. We have different ways we can cannulate it, larger stents, smaller stents. We can remove a portion of the trabecular meshwork, which is the filter. So there are multiple options that can help to improve pressures. But what's really great about it is that the risk of having surgery with the minimally invasive procedure is basically the same as it is as having the cataract surgery. So most of the risk is just getting into the eye. And so it becomes a really nice option without much additional risk to help to treat someone's glaucoma. So when you're doing cataract surgery, you can often improve vision. So glaucoma is not something we can reverse, but we can reverse the blurred vision from cataract, but we can do a little extra at the time. It may help to get people off an eye drop, which can be very helpful, maybe even a couple eye drops depending on what the situation is. And so if you can decrease the amount of time people are putting in medications or the side effects that come with some of those medications, it can be a really nice opportunity for patients.
Is glaucoma as common as cataract?
Not as common as cataracts, no.
Okay.
Thankfully, it's much less common than cataracts. But it is something that is often coexistent in the same age group. So glaucoma also increases with age. So it's not uncommon that patients that are developing glaucoma or have recently been diagnosed with the glaucoma may also be diagnosed with the cataract either around the same time or as they go along. So it's something that pairs very well together.
All right, good to know. All right, let's talk about how great the WVU Eye Institute is. Seriously, I mean, we've got an incredible team. You have a great, incredible team over there. You're so busy. I mean, we're in the process of building a new building. Let's talk. Tell me about the team.
So the Eye Institute is a fantastic place. I've done all my training there. So from medical school, residency, my fellowship, as well as being faculty now, has been at the Eye Institute. So I've seen it through multiple different lenses, if you will, from different perspectives.
Yes.
And I've seen it grow also. And we are filling to the brim. We have this building that we're in currently is really not that old. It's only a little over 20 years.
Yeah.
But we have filled it to the gills, and we are definitely ready for more space. And I think the reason why we've been so successful is because it's a really great group of people that work there, from the physicians that are there, but the entire staff. It's a really nice place to work, and I think patients feel that when they come. I think they feel comfortable and see how much everyone that is providing care for them that day really does care how they're doing. And then we take care of some of the most complex conditions in the state. So if there's a problem really anywhere, it can be sent to us. We're the only group that takes trauma call for the entire state. We're there for all the significant medical problems. And we have the subspecialists to do it. So it's not uncommon where I might be working with one of our cornea specialists or one of our retina specialists, or sometimes all three, to really help make sure the patient gets the care that they need. And that's what's really, I think, unique about the Eye Institute is we're all there in the same building. So if you would be better served by a certain specialist, we can just make that transition happen, or bring in whoever we need to help make sure that person's getting the top-notch care that they deserve.
It's a team sport.
It is. It is. Everything's better in teams.
Yeah.
And it's really a great place not only to work, but also to care for patients.
Well, good. So we've got, I think, a couple years before the new building opens.
Yes, 30 months from February. It's not that I'm counting at all.
And it's just moving kind of next door, right?
It is, yes. It's still on the main campus, so it won't be far. And actually, if you're driving into the main campus of the hospital, you can now see the construction site, and the signage is now up that this is where the Eye Institute's going to be. So it's exciting. I drive by that area every day, and we're really looking forward to the future and what that will bring.
And a parking garage. Parking is so important. Where will you park? Where will you park?
Yes. So huge parking garage that's going to be attached to the Eye Institute with a crossover bridge. So it should be really nice. Well,
we're looking forward to all that. So before we go, I always like to ask, What is the most important thing you want our viewers or listeners to know about cataract?
So I think the most important thing is just to boil it down to remember that the cataract is the lens in the eye that's becoming cloudy. And then when it becomes a problem, when you're having symptoms, you feel like you just can't do the things that you want to do anymore, or you're feeling like you're not seeing as well as you like to be, and it's not correctable by glasses or other things, then it's starting to point towards you might be time to have a cataract evaluation, which can often be screened for, but then when it's time for surgery, then it's time to see your ophthalmologist and have a discussion about surgery.
All right, good to know. Well, thank you so much for sharing all this information with us. I think we can see clearly now, right? Oh, that's a dad joke. All right.
Dad jokes.
Thank you so much.
Thank you.
Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about cataracts and other eye conditions, visit wvumedicine.org/eye. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or on the Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. McMillan and everyone at WVU Medicine, thanks for joining us.